the class? Okay, as discussed yesterday, you remember that I gave you an assignment, right? Right?
Yes, sir.
Did you finish it?
Yes, sir. Oh my gosh. Nagawa mo ba?
Okay. Everybody bring out their assignments. Now, we are going to discuss about it. To start off our discussion, who can tell me what is scleroderma? What is? Anybody from the class? Anybody? My plus points. Mr. Alba.
Scleroderma is a compilation of autoimmune disease which affect the connective tissue of the skin and also the blood vessel wall and also of the internal organ. And it happens when your immune system causes your body to make too much protein, collagen, and important part of the skin.
So, anybody who has additional information? Please.
Skin gets thick and tight, and scar can form from lungs and kidney. The blood vessel may stop from working the way they should. This leads to tissue damage and blood pressure.
Okay, very good, Mr. Alba, Ms. Pesa. Okay, so for the next question.
Sir!
Akala mo, hindi kita nakikita ha? Since you are late, Miss Capito, for the next question, you're going to be answering this. Do you think that scleroderma is contagious or infectious?
Sir, I don't have any idea.
Okay, Miss Capito. So, anybody in the class who is willing to help Miss Capito?
Sir,
Please, Miss Farid.
Sir, scleroderma is not infectious or contagious, meaning you can get it from other people. There is no cure on scleroderma, but there are treatments to relieve the symptoms.
Very good. So, since it is not infectious or contagious, what are the clinical manifestations or signs and symptoms of this disease? Anybody from the class?
Sir.
Please, Miss Soliman.
So, sir, we can use the acronym CREST for the clinical manifestation of scleroderma. So, C stands for calcinosis. So, calcinosis is the deposition of calcium in the skin. It is characterized by people like bumps or nodules that is white or yellow in color. So, the Raynaud'S disease. Raynaud'S disease occurs when over-exaggeration of constriction of blood vessels occurs and it results the color of digitals of toes and fingers may result in color red, white, or blue. The fingers may be painful and feels numb. So for the A, the esophageal dysfunction. So scleroderma can affect the gastrointestinal organs. So it may cause it affects the gastrointestinal motility, and the patient with scleroderma may suffer acid reflux.
You haven't completed the CREST. Who is willing to complete? If you know, anybody from the class? Miss Lardizal.
Sir, for letter S is the sclerodactyly. It is the hardening of the skin that causes the fingers to curl inward, while the T stands for telangiectasias. It is a red spot in the skin. The other signs and symptoms of scleroderma are swelling of the hand and feet, fatigue, short
Okay, very good class. I'm very appreciative for your conversant behavior. But for now, we are going to watch the pathophysiology of scleroderma disease. So, open up your ears and let's watch this video.
For the risk factor, scleroderma is a complex connective tissue disease of unknown etiology, with multi-organ involvement and heterogeneous clinical manifestations. And it is widely believed that scleroderma develops in an individual with a susceptible genetic makeup. Genetic risk factors are connected to human leukocytes antigen, which is HLA complex genes such as the DRB1, DQA1, and DQB1, as well as the non-HLA genes such as NOTH4 and PSORC1. There are also certain other genes acting on scleroderma pathogenesis involved in innate immunity, interferon signaling, and apoptosis-related genes leading to production of autoantibodies. Cell-mediated autoimmunity. If we consider the genetic involvement for individuals' complications, so this includes the CTGF gene and CD226 gene for interstitial lung disease, TNIP1 gene for pulmonary artery hypertension, and HLA-DRB1 for scleroderma renal crisis. The environmental risk factors include triggering events such as the infections of environmental toxin, such as viral infections, Epstein-Barr virus, cytomegalovirus, parvovirus, B18, and certain fungi like Rhodotorula glutenis have been implicated as starting the processes that lead eventually to scleroderma. Occupational exposure includes silica polyvinyls, chloride, epoxy resins, welding fumes, exposure to organic solvents, paint thinners, and aromatic hydrocarbons. Cancer therapy in form of chemotherapy and radiation therapy can also lead to the development of scleroderma. Systemic sclerosis. A combination of these risk factors and other possibly unknown etiology lead to epigenetic modifications like DNA methylation, histone alterations, and formation of non-coding RNA. All of these lead to systemic sclerosis, or the central crisis, characterized by the three main events that cause the clinical manifestations of scleroderma, which are the microvascular endothelial cell or the small vessels damage or vasculopathy, fibrillous dysfunction generating excessive accumulation of collagen and other matrix components in skin, and multiple internal organs and production of autoantibodies or inflammation and cell-mediated autoimmunity. In microvascular endothelial cell damage, the endothelial cells produce a large amount of endothelin-1, causing vasoconstriction and fibrillous activation. Also, fibrillous and activated endothelial cells produce reactive oxygen species or ROS that speed up vascular remodeling, leading to the obliteration of small vessels and impaired vascular flow. Inactivated fibrillars differentiate easily into myofibrillars, which have been increased collagen synthesis ability. Vasculopathy is also considered to be one of the major triggers for the overshooting immune response on scleroderma, and it is postulated that damaged and apoptic endothelial cells release damage-associated molecules patterns, which is the DAMPS, and activate and recruit immune cells. Immune cells are responsible for the secretion of several fibrogenic factors, which are abundant in the blood of patients with scleroderma, and it is responsible for the fibrillous proliferation and extracellular matrix production by stimulating collagen synthesis. And for the skin, according to the systems involved, we'll start with what happened to the skin. First, there is dermal thickening characterized by the proliferation of fibrillous and collagen fibers in the dermis that result in loss of subcutaneous fat, sweat glands, and hair follicles. In the face, this process results in thickening of facial skin and small oral stoma with decreased mouth aperture or hypomenia. Later, atrophic skin becomes shiny and waxy in appearance. As lesions spread proximally, lesions contractured develop at the elbows, hips, and knees. It is associated with secondary muscles weakness and atrophy. There is also tightening of the skin around the fingers or toes called sclerodactyl. Skin ulceration over the pressure points, such as the elbow, may be associated with subcutaneous calcifications or calcinosis cutis. Resorption of the distal tufts of the distal phalanges may occur called acroosteolysis. Hyperpigmented post-inflammatory changes surrounded by the atrophic depigmentation gives a salt and pepper appearance to the skin.
Proceeding to the lungs, the most common pattern of interstitial lung disease and scleroderma are nonspecific interstitial pneumonia, usual interstitial pneumonia, and intimal thickening of vessels that lead to secondary pulmonary artery hypertension, which is one of the most common causes of death in this disorder. The capillary endothelial cell damage leads to pulmonary fibrosis, manifested by crackles, dry cough, and dyspnea. This results in pulmonary hypertension that makes it harder for the heart to pump blood to the lungs. So if this high pressure continues, it puts a strain on the heart, causing right-sided heart failure and arrhythmias from the fibrosis of the conduction system. Other affected areas of the heart are the myocardium and pericardium. So anxiety, fatigue, syncope, chest discomfort, and cyanosis are some of the cardiac symptoms of this disease. Now, the involvement of gastrointestinal tract is typically in the form of collagenous and fibrotic scar tissue replacement of the cells in the intestinal tract, which results in impaired smooth muscle contractility, gastric ectasia, also known as watermelon stomach, decreased peristalsis or lower gastrointestinal tract dysmotility, leading to the overgrowth of microorganisms, possibly manifested by diarrhea, bloating, abdominal pain, loss of appetite, and malnutrition. There is also chronic gastroesophageal reflux, which leads to esophageal inflammation, mucosal ulceration, and stricture formation, leading to the diagnosis of Barrett's metaplasia. Lastly, in kidneys, chronic renal ischemia leads to shrunken glomeruli or glomerulosclerosis. In patients with scleroderma renal crisis, there is fibrinoid necrosis leading to intimal proliferation and ischemic collapse of afferent arteriole that can all ultimately lead to kidney failure. This may manifest as proteinuria when the body starts losing large amounts of protein in the urine. So as the kidneys get worse, extra fluids and salt build up in the body. This might cause swelling or edema, high blood pressure, and higher levels of cholesterol in the blood, also called as hyperlipidemia.
Okay, class. So I hope you understood the video shown about the pathophysiology of scleroderma. So now let's dive into the deeper depths of this disease. Who has an idea what is the diagnostics or the clinical findings of this disease? Anybody from the class? Miss Antila.
How is scleroderma diagnosed? The diagnosis is confirmed by skin biopsy, which shows mucin deposits between collagen bundles in the dermis. There is no single test for scleroderma. It is a clinical diagnosis that requires a thorough exam and history by a doctor. Dermatologists may perform eye skin biopsy to help you, and there are also blood tests, X-rays, CT scans, and other tests that can help diagnose the disease. So the findings is to help determine the best treatment plan that is specific to the system and organ involvement. So meron po tayong mga kailangan i-take na mga laboratory tests like blood test, pulmonary function test, electrocardiogram, echoradiogram, and kidney function po.
Thank you, Ms. Antila, for that clear and thorough explanation. So let's move on. Who can tell me what are the medical managements for this disease? Anybody from the class? Miss Sandaya.
For the medical management, currently no treatment that controls the underlying problem to overproduction of collagen in all forms of scleroderma. So treatment and management focus on relieving symptoms and limiting damage, like moisturizer and lotion. But there are several drugs that are being used, but only a few at this time studies that have been performed. So these are the immunosuppressing drugs, include methotrexate, cyclosporine, anti-thermocycline, mycophenolate mofetil, and cyclophosphamide.
Okay, very good, Andaya. So we can use moisturizers such as lotions and other moisturizers. For the medical or the medicines or drugs, we can also use anti-inflammatory drugs or immunosuppressant drugs. So now for the next question. And I think this is going to be my last question. Who knows what are the nursing interventions for this disease? Anybody from the class?
So after the medical management, we will be I will be discussing the nursing interventions, starting from assessing the patient's vital signs for at least every 4 hours, and then, because for a rationale, we need to monitor the effectiveness of the medical treatment for the said disease, and then administer vasodilators to help dilate the blood vessels and improves the blood flow to the affected area, and then administer analgesic as prescribed. Is to improve or to relieve pain of the patient. Then lastly is to ensure adequate hydration, because adequate hydration helps reduce blood viscosity or pagkalapot ng blood to avoid the clotting factor on our system.
Okay, thank you class for your conversant behavior. So now let us summarize our topic for today. So we all know that scleroderma is an autoimmune skin disease that attacks or damages the connective tissue in our skin. It is not infectious and it is not contagious. Keep that in mind, that will be in the exam. So the clinical manifestations are mnemonics, which is the crest. Keep that in mind as well. For the medical management, we can relieve the symptoms and also limit the damage to our body. For the nursing interventions, we can check our patients' vital signs every 4 hours. We can use vasodilators, and we can also use analgesics and increase fluid intake. So, for our disease, there are a few risk factors. These risk factors include that every scleroderma disease is different from one patient to another. This disease is mostly present between women that are ages 30 to 50. There are no special treatments, although you can see a specialist to have your disease controlled or prevented. And again, keep this in mind, there is no main cause. Okay class, to wrap up our class for today, everybody bring out one whole sheet of paper.